Assalamu alaikum. Welcome to another episode of our health show. Today we have a very special guest, Sister Zainab, who is from Sydney, Australia, and a practicing speech pathologist. Welcome to our show, Sister.
Thank you.
Our topic for discussion today is something that's very interesting. We're going to be targeting children from 0 to 5 years of age and older. The first thing that many viewers would want to know, since it's not very commonly practiced over here, what is speech pathologist?
A speech pathologist is somebody who works in the area of communication and all types of communication. So in Australia, for example, you would find speech pathologists in schools. You would also find speech pathologists in local community health centres, which is where people might take their children to have checkups. You might find speech pathologists in hospitals, and that's the biggest sector in Australia and abroad where speech pathologists work. And there are also speech pathologists in private practice who work in the private sector, and they usually cover a broad range of communication and language impairments and difficulties. You also have speech pathologists that might work in specialist areas, like with a paediatrician or with an ear, nose and throat specialist, as their direct colleagues who work specifically in specialised fields of speech pathology as well.
So you cover every aspect of the development?
Well, every aspect of child speech and language development, and also every aspect of communication. So we might have voice disorders, we might have early language, developing language, pre-verbal language, a child who is developing their language before they even speak. You might be working with people who have disabilities such as autism or Down syndrome, cerebral palsy. You might be working with adults who have feeding and swallowing difficulties or who have communication difficulties as a result of stroke, or even voice difficulties from extreme stress. So, or children who stutter, for example, or children who have speech difficulties, which means they can't produce certain speech sounds. So we cover all aspects of communication, and that can be addressed in a variety of different settings based on the severity of the disorder and also the nature of the disorder and the location of families.
Based on what you said, like you work in the health sector, you work in schools, you work in collaboration with pediatricians, how do you work hand in hand with these health professionals?
Again, depending on the setting, it varies. However, primarily being part of an allied health team means that we work together. So let's take as one example a child who might have autism spectrum disorder. So my role in that child's intervention might be to work on the communication aspects, so speech, social communication, language development. An occupational therapist might then need to work with that child to address their sensory needs and their motor skills, for example. Similarly, you might need a psychologist who works on behaviour and a paediatrician who oversees the development and progress of that child. So although we're working independently with the child on specific areas, we're also working in collaboration. There's constant communication about where the goals are and what the child's achieving, because sometimes there's overlap. So for example, if the child is having a behavioural difficulty, then the psychologist would let me know, and in my sessions I might be then targeting social communication to support the behavioural difficulties. Similarly, the occupational therapist might be working on some sensory processing, sensory information processing difficulties. So a child might need a lot of movement, and they might say, okay, the child is a lot more alert when they are actively moving and they have gross motor movement. So therefore I would then incorporate that into my intervention to get the most out of speech and communication, but also using the child's sensory needs. So we're constantly communicating with one another, and we're constantly working as a team so that the child is moving forward, they're getting consistency, and they're also not getting, they're not being confused with different information from different professionals, because a lot of our fields do overlap with one another. We all have training in the area of psychology and language development, and also child development, and even psychology in regards to adults who are unwell. So we all have that base and that foundation. However, the perspectives with which we use that information varies.
What are some of the examples of the communication problems that you mainly find in children? Probably if you could target the ages from birth to 5 years of age.
Sure. Yeah. So in children, the types of different communication difficulties they could have, again, could be speech. So a child who has difficulties with articulation, they are unable to say certain speech sounds. For example, some children can't say k, they can't say cat, they might say dat. Look at the dat.
I mean, they can't use the tongue properly.
They can't use their articulators. So our articulators
muscles
are our tongue, our teeth, our muscles of our lips, of our cheeks. So they can't make certain sounds. Sometimes they can use them properly. They might be able to say the sound, but then they don't have what we call phonological awareness, the ability to understand when to use that sound. So sometimes it's, an auditory sort of processing type issue. So they might be able to say k, but then they can't say cat, they say dat, or they say da for car, or dite for kite. So that's if they can say the k sound, but some children just can't physically say k. They have no awareness of how the back of their mouth is working. So we would do a range of different exercises to teach them that awareness and then get them to start saying the sound in isolation and then moving them slowly into saying the sound in a single word, in a phrase, in a sentence, and then we would then generalise that into communication. Some children, if they're poor feeders, would have difficulty developing those oral muscles and might have a lot of difficulties producing a whole range of different speech sounds. So the speech pathologist would then determine what sound errors are appropriate for their age and what sound errors are not appropriate for their age, because children develop different sounds at different ages. For example, a child who can't say th at age 4 is normal. It's normal for them to say, I want 3 cups of milk instead of 3 cups of milk, because they haven't developed that th sound just yet. Developmentally, that's appropriate. However, if a child who's aged 4 can't say b, like I want a bag, and they say, ag, then that is not normal for their age, and therefore that would need to be addressed. So that, unfortunately, communication, fortunately and unfortunately, communication milestones are all interrelated to one another. So if a child has difficulties with articulating a speech sound, they would then have difficulties spelling, because if they can't say the b and they say hag instead of bag, when they're sounding out, they're going to put a hurt sound, and it will also affect their ability to read and decode. So it's really important from such a young age that we ensure that the child is developing appropriately. Similarly, we can't push children to develop beyond their age. So we can't push them to be, you can't force a 1.5-year-old to be speaking in complete sentences and giving you a logical argument. It's just developmentally not appropriate. So we need to be cautious all the time of what age is my child? What should they be doing at this age or stage of their development? Are they doing this? If it's yes, then that's great. If the answer is no, then should I be alarmed? What steps should I take to make sure that everything is okay? Now, obviously, we need to allow for, human nature to take its course. You could compare two-year-old children to each other, and one could be speaking beautifully and the other one could still be just forming their sentences or their phrases. So we also need to allow for that variation. But if the gap is huge, if we're looking at sort of 1 or 2 developmental stages, in terms of delay, then yes, there should be alarm bells and we should be looking at some sort of action to be taken, or investigation at least to commence.
So when you talk of poor feeders, children who do not feed properly, what exactly do you mean? Do you mean those children who don't want to eat, or?
No, some children do want to eat, but sometimes they don't have the oral muscles to eat. So some children have a lot of infections, oral infections, they have a lot of mouth ulcers. So feeding for them is a very negative experience. If you ate, just as an example, if you ate something that was, that off the street that you were food poisoned from, you wouldn't go back and eat it again because you did not have a good experience with that meal. Similarly, if children have bad experiences with feeding, so if they frequently choke on their food, or they have undiagnosed reflux, which makes the whole feeding experience very uncomfortable for them, or if they for some reason had difficulty sucking as a child and haven't developed those muscles, or they prefer soft foods or hard foods, then all of that indicates, to us that, the oral muscles, our articulators, aren't being worked to build, because feeding is a prerequisite for speech. So speech and communication starts from birth when a child starts to cry. That, the child is communicating what it needs, but at the same time, it's using its muscles. Whether it's, opening its mouth, closing its mouth, the sucking action to suck, a teat, all of that helps develop the muscles for communication.
So mainly it's a preparation for speech.
Definitely.
So what are some of the causes of some of the communication problems that you have just described?
Okay, so some of the causes vary. Sometimes they're present from birth, so they could be physical. So we just spoke about articulation, that's a physical problem. They could be neurological, so previously I also mentioned children who have cerebral palsy, so that could be the brain messages not delivering the message to the oral muscles for what, so that they can do what the brain wants it to do. So in the instance where a person has had a stroke, for example, they may have had damage to a certain part of the brain, so they might think they're saying, I want a cup of tea, but all that's coming out is, ah.
So they are not aware?
They're actually, they're not aware that that's what's coming out. The brain can't read that because they think they're actually saying something else. And so it could be, and again, that's a physical thing, that the stroke, like it could be physiological in terms of the actual physical dimension of the human anatomy, or it could be neurological. It could also be psychological sometimes. So sometimes people who have voice difficulties and they struggle to get their voice out, it could be because they have extreme stress, and they would need to then address the psychological component of their stress before their voice improves. So, you've got a lot of dimensions that affect. In the area of stuttering, there is, in the research at the moment, there is shown that there might be some genetic links. So sometimes it's genetic as well. So there's a number of causes that can take place with the impairment, and it's important to know that cause, because sometimes knowing the cause helps the intervention, helps the treatment. And sometimes the cause is irrelevant. Sometimes you just have to look at the difficulty that you have at hand and treat it accordingly. And each treatment session with each individual is unique, because although you could have 4 different stutterers, but you need to treat, although that you might use the same method, you need to vary that method to suit the individual, to suit the lifestyle of that individual, and also the family environment of that individual.
The way you have mentioned, it's like you play a role in each of the causes that of the communication problems that the children have. Can you explain our viewers, in a problem like articulation, what is your role in helping those children?
Okay, so in articulation, a child who has just articulation difficulties, which means difficulties with speech sounds, so that means they don't have any intellectual difficulties, they're just a typically developing child who has difficulty saying a few speech sounds. My role is, first of all, to diagnose what are the sound errors, are they appropriate for the child's age. Sometimes I need to look at the causes, so I need to look at whether the child's hearing is affected or not affected. Sometimes we as parents think a child can hear, and they probably can hear, but are they hearing clearly? So a child who has frequent runny noses, who has frequent allergies, who has frequent middle ear infections, is more susceptible to having articulation difficulties, because they're not hearing the sound clearly. They actually have a build-up of middle ear pressure. So if that's the case, I then make sure that the hearing is cleared, and then I proceed to teach the child and their parent how to produce the speech sound correctly, because we produce speech sounds without even thinking about it. But for a child who can't say the L sound, for example, I would have to actually ask them, lift your tongue, touch the roof of your mouth, and demonstrate how they would then slide the tongue across, la. Now we don't think about that, but a child who can't produce that would have to think about it consciously, and the parent would also have to learn those steps consciously so that they can support their child at home. The intervention I do is to teach the sound, but the practice of that sound is the most important component of the therapy. And that practice takes place within the home, because the parents, they're the ones that are spending the majority of the time with the children in that environment, and that's where the majority of practice is going to take place. It'll be very difficult for you to become a professional tennis player if you only practiced for half an hour a week with your coach. you would need to put in a lot more time and effort beyond that session with your coach in order for you to perfect your stroke or perfect types of different techniques. And it's the same thing with communication. Now, the practice is not a long-term practice. It varies from child to child. It also varies based on the environment. But once the child masters the sound and is able to use it in communication, and you don't need to practice anymore, it becomes second nature, like driving a car.
Okay. What about swallowing? For those children who have got difficulty in swallowing, probably due to reflux diseases and those sort of stuff.
Yeah. Swallowing difficulties or feeding in general is a very specialised field in speech pathology, and in Australia it's really limited to mainly the hospital sector, I suppose, or there are private speech pathologists who have a lot of experience in that area and take it on. However, it doesn't just affect children, it also affects adults, and I'll address the children first. Children who have difficulty swallowing, sometimes it could be a physical aspect. Some children are born with a cleft palate, or other children just don't have the muscles to feed, or neurologically, again, with certain syndromes, have difficulties feeding. So a speech pathologist would consult depending on where the difficulty is identified. So with newborns, as young as newborns, a child who is not feeding well, might not be sucking the teat properly, we would intervene at that point in time. Sometimes children who are failing to thrive, who they might be 2 years old but they're significantly underweight, they're not eating despite efforts by the parents to make feeding a very positive experience, we would then consult at that level. Sometimes it's a swallowing problem, or sometimes it's just a general feeding problem where we need to change the nature of the way the child's fed, or change the whole environment with which a child is fed. Sometimes swallowing problems could be a result of a physical problem present at that time. So some children might need a tracheostomy, which is where a hole is pierced into the trachea to aid with their breathing, and that would affect their swallowing and their feeding sometimes because of the breathing and the swallowing at the same time. So the respiration is also involved in that. So there's a lot of different aspects at times that speech pathologists might intervene. Similarly with reflux, we might need to look at modifying the diet. So if a child is refluxing often on certain foods, we might look at cutting that out in consultation with a dietitian, but also looking at modifying the diet in terms of, let's use thickened fluids. So rather than orange juice, let's use mango juice because it's a lot thicker, for example, and the child can manipulate that a lot easier, and it won't cause so much irritation. So there's a lot of different areas associated with swallowing. Similarly with adults who have had strokes or who may have had a brain injury due to an accident, they might also have difficulties with the muscles of swallowing, and there are various sort of technical type of tests that we can do to measure how that whole system is, how the esophagus is working when it swallows. We do what's called a modified barium swallow, and based on those results we would then look at modifying the diet or advising different dietary options or different methods of feeding to avoid choking, or to avoid something that's called aspiration pneumonia, which means that the food goes into the lungs in error because we don't have the muscles to control the food, and therefore we end up developing pneumonia because a foreign body is in the lungs.
In the third aspect, language and literacy, how would you help those children?
Okay, language development or language in general is a very key component of the speech pathology field. So when we talk about language development or language, we need to understand that it's not just words and it's not just a specific language like English, but it's also our non-verbal communication. So I could use a number of signs like stop, you go, and before I even say the words, you're understanding what I'm saying. So that's really important in language development. And
it's a part of communication.
Most definitely, and it covers areas like vocabulary, sentence structure, so the ability to say a sentence in the right order, our ability to express our thoughts and our ideas in a clear and coherent manner, and our ability to transfer those thoughts and ideas then into literacy, into reading and into writing. And they're all linked to each other. So for let's say a child who is 4 months old, already we're looking at their language. They can't speak, but we're looking at, are they attending? Are they looking in my direction? When I turn my head and say, boo, are they engaging? Because they're the pre-verbal skills that a child needs, and already communication is happening. So if I say, where's the shoe? Where's the shoe? Let's move on a bit more to a child who's 10 months old. Do they go to the shoe or look at the shoe because they understand what that means? Or do they just look at you with a blank face because they have no idea what they're saying? Because language comes in two components: receptive, which is how much we're understanding, and expressive, which is what comes out. So receptive is, I'm understanding, without my mum saying, go get the bag, she doesn't need to point at the bag, I know where the bag is. Or if my mother says, put the bag on the table, I'm actually putting it on the table, not under the table, because I know the difference between on and under. So all of that comes into our understanding, our receptive communication, or our comprehension. Similarly, when I go to speak and my mother says, what would you like to eat? A 2-year-old shouldn't be going, to the fridge. They should be able to say basic words like milk or juice or whatever vocabulary has been introduced to them. But we also have milestones, even for language development. So a child who's 2 should have a vocabulary of at least 50 words. A child who's 2.5, 3 should be combining words. By 3.5, they should be speaking in basic sentences. By 4, they should be having more complex sentences. And we look at things like, are they using plurals? Are they using pronouns? I, me, you, he, she, they, and do they know the difference between them? Are they using prepositions in, on, under, next to, behind, over, under? Are they aware of what they mean, and are they able to use them? Are they using past tense, regular past tense like clap, clapped, or irregular past tense, throw, through? So all of that, obviously different ages carry different language dimensions with them, but we need to make sure that the child has all of that and it has acquired all the language that they need, because language really affects reading. If I don't understand what certain words mean, even if I can read and sound out shop, but if I've never heard the word shop, I'll never be able to say, oh, that's shop. But a person who knows that word says shop, shop. It's the word shop. A child can read it straight away, and there's a breakthrough. So it's really important that a child has a good stronghold on spoken language in order for them to achieve academically with literacy and with writing.
What about voice disorders? Like, what kind of voice disorders do you have in?
Okay, there's a range of voice disorders based on, I suppose, the causes. So if we go back to some physiological causes, sometimes it's about strengthening the muscles associated with voice, or teaching people how to use their voice well. So we have, what's very common in Australia is vocal misuse, particularly in children who are sort of 1.5 to sort of 4.5 years of age. So when a child has a very hoarse voice like this, we are very concerned, because that is not normal. There's a problem, and we need to look at why. Usually the child throws a lot of tantrums, and because they're constantly tantruming and constantly crying, it then affects their vocal folds, and they start to develop something called nodules, which is tiny little sort of, I suppose the parable is like a callus or little lumps on the nodules, which makes it very hard for the vocal folds to function appropriately. Now, if they go untreated, those nodules could become quite dangerous. They could become polyps and even cancerous down the track. So usually what we do is we try and address that by teaching children. You can't stop a child from yelling and screaming and shouting, but we can maybe address their behaviours to teach them different ways to express their dislikes, or different ways to have a tantrum, or teach them how to use their voice well. So show them good shouting, which is from below in the diaphragm, versus shouting from just up here and putting a lot of strain on your voice. And through intervention and education and changing those habits of the child, you can actually reduce the size of the nodules and even eliminate them. That same issue is faced often by teachers or sports coaches or people who use their voice a lot and need to project their voice a lot, even singers and professional actors. So it's about teaching them how to use their voice well, how to project their voice, how to warm up the voice, just like we warm up before we do exercise, before we go for a run and we do our stretches. There are also stretches we need to do to warm up our vocal folds, particularly if we're going to be using them excessively, because they are muscles. They're not muscles that we think about very often. And a lot of people, the first time that they really feel or become familiar with their I suppose their vocal fold muscles is if they've been to a function where they have to speak very loudly, all evening, and the next day their voice is barely coming out and it's very strained and very strangled. So, they've worn that muscle out or they've exhausted themselves. Similarly, there are a lot of exercises that we need to do for people who have stress-related voice disorders. There are a lot of relaxation exercises associated with the head and neck that we do to release tension.
What do you mean by stress-related voice disorders?
So, for example, when you call your friend and you speak to her on the phone and she says, "Salaam alaikum," from her voice she's very down, versus "Salaam alaikum." So our state of mind affects the way that we use our voice. So some people who have high stress actually have difficulties using their voice, difficulties projecting their voice, and even difficulties just getting their voice out, because the muscles in their in their head and neck are so tense that they're not able to project. So again, that's where we overlap, maybe like I mentioned before, with the field of psychology. They might need to be getting some sort of psychological support to deal with that stress. But we might also be need to teach them how to do some stretches of the head and neck area to release that tension on a physical level to assist them. Also vocal hygiene, so frequently sipping water, staying hydrated is really important. Minimising caffeine, which dehydrates you and affects the voice. So all of those types of things, we look at the entire lifestyle, and then we start to look at strategies to help that person so that they can use their voice well and use it effectively.
There are other modes of communication mainly used by children who cannot see, cannot talk. Even those patients suffering from stroke, they use that aided mode of communication. They use the multimodal communication.
Yeah.
How do you help in that area?
Sure. So sometimes it's, like you said, it's called multimodal communication, and some people refer to it as alternative and augmentative communication. They are used in the instances where no speech is present at all. Or very little speech is present, and nonverbal communication can only get you so far. Some of the most basic modes of multimodal communication is picture books, whereby children are taught pictures or taught receptively, words, and shown pictures in categories. So foods that they might eat, things around the house, things associated with school. And based on that, for breakfast, Mum might say, "What do you want to eat?" And we would have developed for them already, we would have consulted with the parents and worked out all the different words that child would need to know in their vocabulary. We would then make sure that the child understands the picture and the word. So cereal, apple, banana, so that they're able to identify what they're hearing, the word with the picture, or some of them can't hear. So a picture, what it is, what you do with it. So we need to make sure that they're understanding what this is, and then we teach them how to use that expressively. So I might receptively be building their communication by teaching them what they all mean, and then expressively they would then use it when I might say, for example, "Adam, what would you like for breakfast?" And Adam might point to some cereal, and I say, "Oh, you want some cereal?" And then he might say yes, and then I might even have a further breakdown depending on how choosy Adam is with his cereals. I might have cornflakes and Wheat Bix and Cocoa Pops. Which one would you like today? And then Adam would pick that picture. I have liberated him in the sense that I'm able to give him a mode by which he's able to express himself, and also Mum is not frustrated, or anyone in the home, because they know what Adam wants. If he didn't have that, he could be pointing at everything for such a long time, and everyone's trying to find out what he wants. And then the vocabulary builds into categories. So they might have a whole book of different pages for different things. Alhamdulillah, with the progress in technology, that has now moved to iPads, and handheld devices where children can, use a whole range of different programs that have been developed where they just press on a button and it could even say a sentence for them. I want to go shopping. Or another sentence, I want some milk. I don't want to sleep now. So that they're, just with a press of a button, a symbol that identifies what they want to say, they press that. So we teach them again receptively which picture means what sentence, and then they use that expressively by pointing to what they want. Now obviously physically they need to have the physical aspect, and that's where we come in. Sometimes parents are very hopeful that they want their child to do a lot more than what they're able to do, but mum might say, oh look, he understands every picture, but is he able to use his limbs to press what he wants? If he's not, is the picture system better? Or in the instance of some children who are totally immobile, you might have pictures all around different sections of the house, and you might need to hold two pictures and they use eye gaze, pointing with their eye with which picture they want. So the speech pathologist looks at the child as a whole and looks at what is the best mode of communication, what can the child use based on their understanding and their physical abilities, and also what works in the family context as well. Because if a child can use the iPad but the parents never charge it or they don't refer to it, then that's not going to work for the child, even though the child can use it. It might work really well for this person but not necessarily for this person because their family context is different. So we really look at the lifestyle of the families, what they're able to use and how practical it is. Taking an iPad to school, for example, is not necessarily practical sometimes. So then we need to decide, okay, do they have a book for school and an iPad for home, or do we just take the book everywhere? Right down to, do we use cartoon pictures or real photos? So we really, look at what...
Depending on what suits the family the best.
It's catered specific to the child and their family. Yeah.
Another problem that not many, a few have it, stuttering. How would you help those children and even the adults as they stutter?
Yeah, stuttering is a fluency problem which is neurologically based, but it's treated through behaviour therapy. Stuttering, I suppose, it first becomes apparent in children aged sort of 2.5 to 3.5 years of age. We all stutter. We all have stuttering in our speech. However, it has to be it's less than 1% of our speech in typical communicators. People who stutter, they have disfluency in more than 1% of their speech, and they become very difficult to understand. Children aged 3.5 to 4.5, it's natural for them to stutter on and off. It's part of them learning, particularly children who speak two languages. Sometimes they're thinking, and they all go through what we call a natural period of stuttering. However, if a child stutters for more than 6 months, that's when we need to be concerned. Similarly, a child who starts to stutter for more than 6 months and is around about 4 to 4.5 years of age needs to sort of seek immediate intervention, because all of the research has shown that a child who has intervention before the age of 5.5 can pretty much eliminate the stuttering and reduce it right down to below 1%. Whereas children who have been treated after that age, it's very, very difficult to eliminate the stuttering. You can reduce it, but you can't eliminate it. And sometimes even just 2 or 3% of stuttering really affects the person's quality of life, and it affects their self-esteem, and it affects the way they're perceived in the community, because generally we tend to perceive someone who stutters as someone who's not necessarily intelligent, which is not the case. They're very intelligent, they're just not able to get the words out in the way that they want. It's blocked or it's repetitive, and they have no control over it. So we try to teach them control. Going back to the children who, and not just, it's not just children below 5, but children in general, the stuttering therapy is administered by the parents. So the role of the speech pathologist there is to teach the parents how to do the therapy, and the parents continuously do that on a daily basis, from anywhere from 12 to 12 weeks onwards. Ideally, 12 to 15 weeks is the treatment time for children under 5 years of age. It's much longer for older children. But it's really the family who plays the role in that, and that is under the direct guidance of a speech pathologist. It's very, very hard for a parent to treat stuttering on their own, even if they do the reading on it. The speech pathologist models it for the parent. The speech pathologist then teaches the parent how to do it and provides the parent with feedback on how they are doing the therapy. So in Australia, a very successful program called the Lidcombe program is used, and it has had the results are extremely promising.
How does this program work?
It's based on on praise, positive and negative reinforcement from the parent. However, the ratio of praise needs to be much higher than the negative reinforcement, and it's very, very, very specific in how it's done. So, you know, parents often read about, oh yes, that sounds fantastic, I'll go and administer that. But unfortunately, if it's not administered correctly, it can actually do more damage than it can.
So it's specific for specific children?
It's specific for the child, and it's specific for the family, but it's also, the program itself has a formula that needs to be followed and adhered to. And it's really about, again, the parents. So oftentimes we find if a child's not progressing, it's because the parents are not administering the therapy correctly.
The parents are trained on how to train their children.
Exactly.
What about information processing? How do you help children who have got difficulty in information processing?
Yeah, so information processing comes in two forms. It could be in visual processing or auditory processing. So how we process the information that we receive. So in terms of visual processing, oftentimes we refer children to either an optometrist if it's a physical problem, or an occupational therapist if it's a spatial perceptual problem where the child is not able to track letters or able to sort of look from the board back to the page and things like that. Or when they're reading, they're skipping lots of words. But in terms of auditory processing, how we process the information we hear, basically we train the brain to attend to key bits of information. Now, sometimes children don't have enough vocabulary to process information. So it's not that the child's not processing the information, but they don't have the language skills to process the information. So if we build their language, their ability to process information is automatically corrected. However, children who have difficulties like hyperactivity, attention difficulties, autism spectrum disorder, they naturally don't attend. And so we need to train them to attend to information. So oftentimes you might say to a child, how old are you? And so how are you? And they'll say, I'm 5. They're not processing the information that you say. They're just hearing the how, and then they're assuming the rest, and they're answering back. They're thinking that we've asked how old they are, but we're asking how are you. So there's a lot of exercises, again, very structured and very systematic, which we introduce to the child in the clinical setting. But then the real intervention, again, is back in the home with the families. We give them a lot of exercises, and we can basically train the brain to listen. We can train the brain to remember information. We can train the brain to remember small bits of information, larger bits of information, understanding when someone asks me a specific question, what they are seeking. So if I say to you, where is the bag? You don't say, oh, that's my, daddy. It's not a who question, it's a where question. So again, filtering what I'm being asked and how do I answer that.
And the last one, those children with disabilities, how would you help them in communication?
Okay, so it's very, children who have disabilities, depending on the disability, you would treat them. And different children, different disabilities also have different levels. So if you look at autism spectrum disorder, for example, not every child who has autism is at the same level of autism, and they are not necessarily, they don't have the same features of the diagnosis. So you would look at what the child is missing in their communication, and then you would try, if they have the skills, to introduce those aspects of whether it be speech, whether it be understanding in terms of receptive communication, or maybe they understand everything but they're not using themselves expressively. So let's say there's a child with autism that only uses verbs. Well, I would then need to teach him how to use nouns, adjectives, and a whole range of other words to formulate sentences. Similarly, some kids don't use verbs at all. They just say, I shop. instead of I am going to the shop. So again, we would then say, okay, well, let's introduce verbs. So it's always catered specific to the needs of the child. Down syndrome, for example, you might have a child who has very good receptive communication and very good expressive communication, but has speech sound errors because they have a heavy tongue. They might not be saying the S sound properly or other sounds. So we would teach them how to make the sound so that they can use the expressive communication that they have, and they could be understood clearly by people that they are speaking to. You know, children who have cerebral palsy, for example, or children who might have hearing impairments. Again, you would cater it specifically. You would assess their communication and look at what's missing, and based on what's missing and based on what's important developmentally or what's important to their environment, you would then introduce that slowly to them at the skill level that they have.
In Tanzania, we have quite a number of children who suffer from stuttering, which is another voice communication disorder. Can you please advise our viewers on what are the treatments and the steps of treatments that are required to treat them?
So with stuttering, as I mentioned before, it's a very, very specific treatment that needs to be identified. But I think the key thing with stuttering is, as parents, we need to be looking at, has my child been stuttering for more than 6 months? If the answer is yes, then you need to seek intervention immediately.
At a very young age, you say it starts at a very young age, right? So how can the parents know that my child is not exactly trying to talk, but my child is actually stuttering?
Well, I mean, again, that key indicator is that 6 to 7 month indicator. It's very natural for children to stutter, but not for more than 6 months. They might do it for 3 or 4 months here and there, or they might have difficulties with finding the words that they want to say. That's very different to someone who is really struggling to, and I went to the shop.
Which is not normal.
That is, it is not typical, language or fluency. So that 6 month, let's say 6 to 8 month indicator is a key alarm bell, I think, for a parent is, okay, this is typical language development. Okay, this is not typical anymore. It's been going on for too long. The child has not been able to overcome it naturally. We need to look at family history. So is there anyone else in the family who stutters? Because more than likely, again, there's been a lot of research into genetic links, and although it's not conclusive that it's genetic, but there are strong correlations, particularly with boys. So, for example, if the father stutters, the grandfather stutters, then it's very likely that a child will stutter. Which then again, that information coupled with the information that you have, with the child stuttering for more than 6 months, the parent starts to think, well, I need to seek intervention. Now, intervention for a child under the age of 5, if they're using the Lidcombe program, should be anywhere from 10 to 15 weeks in terms of the success rate. It needs to be weekly, and it's 1 hour a week of therapy. So that's why I mentioned previously, it's not something that a parent can just do on their own. Parents need to seek out some professional support and assistance in that area, whether they travel abroad to get that support, or if there are speech pathologists locally, then to also seek their support and to continue with that support. Even if parents sometimes become confident, think, well, I can do this, I don't need the support of the therapist. Unfortunately, we've seen it many times. The second parents get to that point, the child regresses, and it's much harder to gain or regain what you have previously gained in terms of speech fluency. So it's really important that, stuttering is one of the impairments that does affect people's self-esteem into adulthood, and affects employment opportunities, and even affects their education when they're presenting speeches at school. Some teachers disregard the impairment and expect proper presentation. So it's really important that we take it seriously. For children who are older than 5, where you can't necessarily eliminate the stuttering, but you might be able to reduce it. Again, it's really important to get professional support on a regular basis. With the older children, when they're about 7 or 8, they themselves feel very frustrated and are really seeking support. And again, even if it's monthly, it's something that assists the child and the families and there's lots and lots of different strategies that can be used, but it needs to be really under some professional supervision.
If treatment is sought earlier, is there like a 100% rate that the stuttering will go away, it will be cured, or is it that it will be decreased?
It's not guaranteed. It varies from child to child. There's a very, very high percentage of children where the stuttering is less than 1%, which is considered normal or typical. So we all stutter. When we're tired, we might stutter a little bit more, or sometimes we're thinking and, we stutter. Everybody stutters. But the percentage
it's only 1%.
It's less than 1%. And when we measure the percentages, we're measuring syllables. So we're measuring syllables stuttered versus syllables spoken in general. So it's less than 1%. Children who have, some children, they can never totally eliminate it or even reduce it below 1%, but they can get it around to 2 or 3% where it doesn't affect their quality of life, where it's not very, very evident that they're stuttering. And then we teach them strategies as well to help them overcome even those instances where, some people who stutter, as soon as they stutter, they panic and it gets worse. So again, it's a psychological game. It's like, don't panic, just keep on going. So that, we teach them strategies to overcome the instances whereby they do stutter. Over the age of 5 and into adulthood, the goal is not necessarily to eliminate it, but to reduce it to as low as possible so that communication is clear, easy and effective.
We have the part of our aging population who are very prone to stroke, and because of that they tend to lose their capability to speak or to express themselves. What is your role as a speech pathologist in that field?
So usually when speech pathologists see stroke victims, it's either in the hospital immediately after their stroke, or we see them as outpatients, which means they've been discharged from hospital but they need continued support, and so they would see us weekly. It's really important for families supporting someone who's had a stroke to understand that at times parts of the brain have been damaged. Sometimes speech pathology and occupational therapy and physiotherapy together can work to teaching the brain a new pathway to achieve a certain skill, and sometimes we can't. So I think the goal is to make the person as comfortable as possible. So one of the first things we look at for someone who's had a stroke is their swallowing. Have the muscles, for the esophagus, the articulators, the trachea, even the diaphragm, have they been affected by the stroke? Based on where the lesion is in the brain, you would then know where the damage has occurred to all the other aspects of the body. Because, for example, if the stroke happens on the trigeminal nerve, which affects speech and swallowing, then I know that this person is going to have speech and swallowing difficulties. But sometimes the severity varies depending on the severity of the stroke. So if somebody is struggling to drink a glass of water and they're starting to cough and splutter, then I know that this person can't have thin fluids, and I would need to be offering them thicker fluids like apricot juice, mango juice, guava juice, because that is easier to manipulate. Similarly, they might not be able to chew very well. If that's the case, we need to be mashing their food up for them like we would for baby food, and then offer them that food. In terms of their language and their communication, the first 3 months after a stroke, the more work that we do with that person in trying to get them to try and speak again, or try and move again, or try and do anything that they're not able to do, that is like, it's like early intervention, I suppose. That's the time that the recovery is that the success is higher. As we move forward, 1 year post-stroke, the success rate at achieving new skills decreases. 2 years, it's less.
So the sooner the better.
The sooner the better. So the more we try to work on even just building oral muscles, ooh, ee, ah, ooh, if they can't speak at all, or if they can speak but they're struggling to find words, maybe offering them support through pictures. So, so that, oh, do you want a bag or do you want soap, for example? And they, soap, because the picture, the visual support helps them with the word, and then all of a sudden it's, hopefully it's not so hard to say soap anymore. Sometimes they might always need a few visual aids to get their message across. But it's very, very frustrating to have an adult who has been fully functioning, sometimes the head of a family or running a business, to be so debilitated. And it's frustrating not just for them but the people around them who are trying to communicate and offer them what they want. And oftentimes we then have issues such as depression following that. So making sure that their state of mind is kept high so that they're able to then function and achieve the goals that they want. If not, then maybe refer them to some special support, welfare or psychology. So all of those things are really important for people who care for someone who has a stroke, to be looking out for how they're feeding, how they're moving, how they're communicating, and what's their self-esteem like.
You, in my previous questions, you mentioned that you tend to support children who are from 0 to 5 years of age. So how do you support these children into building their communication skills? Okay,
well, oftentimes there's a range of ways. I suppose in Australia, and I suppose you could adapt it here in Tanzania, is speech pathologists go to a lot of preschools and do parent information sessions with parents of children who are just emerging into communication, so that 2.5 to 3.5 year range. Also, there's a lot of education in baby health clinics about communication and communicating with children. When you get to a point where a child sees a speech pathologist, that means that there's a problem. So we try to avoid the problems through education. So for example, if we go back to a baby, the fact that the baby is looking at you and sharing your attention with something is a really good sign. They're already communicating with you. If the baby likes a rattle, and they look at the rattle and they look at you and they look back at the rattle and they look back at you, they're communicating with you. So they're pre-verbal skills, and they're really important skills to have in communication. We don't think anything of it. We think, oh, that's nothing. But a child who has autism, for example, has a lot of difficulties in joint attention, in sharing some sort of communication with you. Looking at it, again, looking at an item and looking back at you. They might look at the item if they really want the item, but you don't exist. So therefore, how can they communicate with you? Or how can they learn from you? Ball. If they're not looking your way when you speak, how can they ever know that this item is a ball? They might think that the bag could be a ball. So we take for granted how children learn language. We find often that children who have really good communication and good vocabulary are the ones whose parents actually speak to them a lot. So it's really important that we're communicating constantly with our children. This, that, here, there, they're forbidden words. We can call them haram words. Everything has a word. Get the bag and put it over there. Where is there? Is it next to the stairs? Is it on the table? Is it under the chair? Because we're learning our prepositions with under, over, on. So it's really important that we're very specific. Give me that thing. I need it now.
What thing?
What is it? What is that thing? So all of a sudden the child says thing, 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 and they're missing out on opportunities to develop their vocabulary, because every single thing has a word. And often children learn through play. So we as parents might not necessarily have time to sit and play with our children, but we could talk about what we do. Mummy is cooking. Mummy is chopping the carrots with a knife. What is this? And then the child might say carrot. Good boy or good girl, you've learnt. What's mummy doing? Chopping. Can you chop? And you might just give them a fake wooden spoon. Chop, 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 chop. Let's stir. And we look for opportunities to introduce vocabulary in all environments, in the kitchen, in the bathroom. Let's wash our hair. Let's scratch. Let's scrub. Let's rub smoothly. Let's go rough. So again, we're introducing a lot of vocabulary to build understanding. Now the child might not necessarily repeat it immediately, but somewhere down the track they might, particularly if that information is repetitive or it's used frequently. It's also really important that we look at our children when we communicate, because we're placing the emphasis on them looking at us to learn, but if we're not looking back at them, then how can we have their attention? So we need to be face to face with little children who are sort of 2.5, 3, go down to their eye level and speak to them. Now we don't always have the time to do that, but wherever possible. playing a lot of people games or saying a sequence and then stopping. So, Bismillah ar-Rahman, and just pause and see if they can finish your sentences. Similarly with nursery rhymes, twinkle, twinkle, little, and see if they can finish it. And then slowly take away a bit more. Twinkle, twinkle, and then they say little star. So, doing lots of language games, looking at books together and just labelling everything so that you're building their vocabulary. And for young children in particular, the visual support is really important, more so than the auditory.
Understand better.
That's right. So, this is a cow. What's the cow doing? Oh, he's eating. So you're building verbs automatically. So you've labelled the noun, which is the cow, and then he's eating. What's he eating? He's eating straw. Oh, is the cow happy or sad? So all of a sudden we're introducing emotions. So just talking about pictures. You don't have to read a book to a child. Even if you just discuss the pictures, you'll be building a lot of vocabulary, and there's a lot of interaction happening between you and the child as well. So that's a really important thing, I think, as parents, that we need to pay attention to. It's very oftentimes we think, oh yes, they're at school and they're learning from school, or they're watching TV and they're learning from TV. But human interaction is the best form of learning, and we need to really keep that in mind when we're with our children. And also there's nothing wrong with bilingualism, with learning in two different languages, as long as we don't mix the languages into one sentence. So, I don't want to say, can you please give me some masare, which is money in Arabic. I should be saying, can you please give me some money? Or I should be saying, atini masare, like the whole sentence in Arabic, or the whole sentence in English. But the language mixing later on down the track leads to weak vocabulary in Arabic and weak vocabulary in English.
You're mixing, the child gets confused.
They get confused. So you might want to either say the entire sentence in English and then the entire sentence in any other language that you speak. Or what some parents do is they speak English in the morning and Arabic in the afternoon, and then a couple of weeks later they switch it around so that the vocabulary, say for bath time, is developed in English and is also developed in Arabic, for example, or any other language that someone speaks. And that way you have true bilingualism. You will always have one language that's stronger than the other, but at least it's two strong languages and not two weak languages. Oftentimes I see children who speak other languages and they're 7 or 8, and they'll say, I'll say, what would you like to eat? And they say, oh, I want some of this. What's this? That one there. What is that? They can't even give you the word. And then they might say in Arabic, batikha. Oh, that's really good. What's it called in English?
You get confused.
They go to school. They are exposed to lots of language, but because they only use the word batikha at home and then parents mix it in the sentences, they're not able to translate in their own minds that batikha is watermelon, for example. So there's a lot of sort of strategies that we as parents, we need to be very aware of when our child is developing, particularly from 2 till 4 years of age, or from 2 till 5 when they first start school, because all of that language is going to affect their academic performance. It's going to affect how they understand the information that the teacher is giving them in the classroom. It's going to affect how they decode when they're reading, even how they write their sentence and the words that they might use for a sentence when they start writing at 5.5 or 6 years of age. So all of that is really, really important for them, and it's also important for their ability to get their message across and to express themselves.
Okay. As we are approaching the end of our show, Sister, what advice would you like to give our viewers?
I suppose the most important thing at this stage is, if you are concerned on any level that your child or a family member is experiencing a difficulty in their feeding or their communication, seek intervention and seek support. And in the area of children in particular, spend as much time communicating with your children as you can. Don't rely on somebody else to do it for you. It's really important that we take the time. Our children are only young once, and we're only going to have one chance at giving them this opportunity to develop all of that beautiful communication that they need, which is a lifelong skill.
Thank you so much for coming to our show, Sister. You have shared some very valuable information to our viewers. Thank you so much.
Thank you.
Khuda Hafiz.
Khuda Hafiz.